Okay, so I think we'll get started. Good morning, everyone. I'm Pedro Delgado, and I work at the Institute for Healthcare Improvement, and it's a real privilege to be here with you, and it's a real privilege to be here with Pierre and Nigel to exchange some thoughts with you about some theories of change and some realities that have been emphasized throughout. And if any of you or all of you were at Jim's session, some of those thoughts might be reinforced here, particularly in relation to the exciting possibilities that lie within exchanges. And this is a good demonstration of that, the fact that we're all here together. So these are the aims that we have, the aims that you have in your brochure. We hope to enhance efforts by reflecting with others, so we'll have you interact at different points. Promote bi-directional learning between developing and developed and develop and developing, truly bi-directional. To continue to build personal and professional improvement networks, and to explore further relationships with those individuals or institutions working on similar topics. This might be a consequence of some of your discussions, and this is roughly how we're going to break it up. So I'll do a very quick introduction. Nigel will talk about global health. Pierre will talk about large-scale change, and then we'll share with you some mechanisms that we're considering for cross-learning, for trying to maximize the power that lies within that. And this is partly where we're coming from. We've been blessed with the possibility to learn from many parts of the world. Initially, IHI was a US-centered organization, US-founded, still US-based. And throughout the years, we've been blessed to be able to exchange with up to 120 countries or so. Some at a very shallow level where we just learn, and some at a deeper level where we learn and we teach and we learn and we teach. And once that relationship gets started, it's usually a lifetime relationship of caring, of improving, and of learning. So this is the world that we live in. Many of you might have seen this. It took radio 38 years to reach 50 million users. It took TV 13 years to do that. The internet just 1 year. iPods, because of the commercial nature, 3 years. And Facebook added over 200 million users in less than a year. So this is a sort of scary speed in many ways that we're looking at in terms of technology. This is just one element of the things that we have to consider, but also of the tools that we have at our disposal to be able to use to generate this shared learning. And we're calling it a new global perspective. It is a global perspective. We're impatient about improvement, so we want to hasten the pace and the scale. We know, we realize, we acknowledge, and we actually bring it in as a core element of everything that we do, that there's an interdependence globally with common issues. Some are common. Chronic conditions has been mentioned throughout this meeting. Surgery, safe surgery, it's a global problem. And some are more local. I think the big difference and the big challenge here is the difference in context. But in terms of content, there's a lot of things that I think we can learn from each other. Health innovation is occurring everywhere. And everyone has something to teach, and everyone has something to learn. And we have multiple networks. Within IHI, you have multiple networks within your organizations, or within your institutions, or within your systems. And naturally, the connections are made. When we are seeking answers, we may not go next door to Harrogate, but we do seek to, and there's a reason why you're here. And many of us, I include myself in that, but probably it's the main reason why I started coming to these conferences a number of years ago, is because I wanted some answers, and I wanted some space to reflect and be able to look at what I had been doing and what I needed to do as an individual and what we needed to do as a system. But we're trying to perceive or frame this as a living global network. That's what it is. These things have a viral nature to them. So once you start to understand that people just connect because that's our human nature, and when knowledge is involved, that's maximized. We've started framing things in a very different and dynamic way that we hope will take us to a place where we can truly accelerate global improvement and perhaps live by some of those global constitution principles that Jim outlined during the last session. So there's two thinking pieces that we want to exchange with you, and the first one, I hope to introduce you properly, Nigel. It's Lord Nigel Crisp. So this was my ignorance. The last time we were speaking together, I introduced him as a sir, and there's some sort of distinction between a sir and a lord. But I'm from Venezuela. We don't have sirs or lords or kings or queens. So I was forgiven that time. So Lord Nigel Crest will exchange some thoughts with you in relation to some work that he's been doing for a lifetime, really. So Nigel.
Well, thanks very much indeed for that, Pedro. Yeah, I'm not going to go into the explanations of British titles. That would be at least an hour to try and explain how the various bits fit together and how the various bits don't fit together as well, which is also very important. As Pedro just said when we were assembling here, we actually expected this to be a room with tables, and we were going to get you to do some table work after we'd put in a couple of think pieces, really. So I'm going to start off, and I'm going to talk to you about how important it is, really, some of the theory, and about how important it is that we do set up mechanisms to learn from each other, because there is so much that we need to learn from each other, and there is such an imperative about it. And when I say learn from each other, I don't mean the sort of top-down Western European, American knowledge being transferred to other people. Knowledge transfer is both ways. And we need to start to think about that, I think, in rather different ways. So I'm going to do that, and then at the point at which I finish my piece, what I'm then going to do is turn to you and to ask you to think for a moment about where you may be able to learn, or where you have been learning from people in completely different contexts, and then share some of that with us. So that's what we're going to try and do. I don't know whether we've got any microphones out there, and I'm hoping that at that point the lights might go up so I could actually see if there's anyone out there anyway. Because at the moment I just have lights in my eyes. So that's what we're going to try and do. But I'm going to just take 20 minutes to just talk through some of this. So you'll see up there, in fact, the title of a book which Maureen very kindly advertised for me, I noticed in her session on Wednesday. It's called Turning the World Upside Down, because it's actually, the title actually comes from a journey that I did. I ran the NHS in England for a few years, and then at the end of that, the Prime Minister, Tony Blair, asked me if I would look at what more we could do from the UK to share our experience and our expertise in healthcare with people from low and middle income countries, so that we could offer some knowledge transfer and some support to them in terms of their development. And I did that, and I spent a bit of time looking at that, and I discovered there were some real things that we could do from the UK, and indeed from Europe and America, and lots of things that were going on, and more that we could do. But I also discovered, and I hadn't expected to do this, how much we had to learn. And that's why I've entitled this Turning the World Upside Down. And it's based on, I think, a couple of things. The first thing that I ought to start off with is, what's the context we're talking about? Pedro already mentioned interdependence. And it's just worth thinking a moment about the various ways in which we're interdependent. I mean, the first and most obvious way we're interdependent, of course, is just in terms of diseases. The fact that a disease could incubate anywhere in the world and be with you within a day or two. I mean, we know that the Black Death in the 14th century took 3 years, took 3 winters to get across Europe. But we also know that SARS at the beginning of this century took 3 days to get around the world. We are all vulnerable to disease wherever it's being incubated, and for all of us it's therefore very important that the weakest health system in the world gets stronger, because we share their vulnerability, because what's ever happening out there will be on our doorstep wherever we live and however safe we live. But that's not the only way in which we're interdependent. We're interdependent in terms of using the same staff. Health staff move very freely around the world, and I'll come back to that in a moment. We use the same drugs. We're vulnerable to the same environmental issues, whether we're talking about climate change or whether we're talking about a volcano affecting people, whether we're talking about a nuclear problem in Russia affecting health in Wales. These sort of issues are with us wherever we are in the world. And we're also interdependent in a way that actually is also quite risky as well, which is we are increasingly interdependent around the same body of knowledge and the same way of looking at the world. And that can be quite risky because it can actually leave out some of the other things and the other knowledges that are around the world that we can perhaps learn from. So we're interdependent. It is the key sort of aspect of healthcare in the 21st century. Now, I actually talk about something which, and forgive me if there are economists in the room, which I describe as an unfair health trade. And the unfair health trade that I'm talking about is that we in rich countries tend to import health workers from poorer countries to come and work with us. And in return, we export our ideas and our ideologies, whether they work or not. So if you happen to be working in Africa, you'll come across American health workers who may well be thinking in terms of health insurance systems. If you meet British health workers, they will have a frame of references that's about the NHS and will be wearing their NHS spectacles, as it were, in terms of the advice or the work that they're doing with people locally. So we have that sort of trade at the moment. It's not proper trade, but it's a metaphor where we take health workers, but in return we export these ideas and ideologies. And I argue, well, what would it be like if we did it the other way around? If we actually started to import some of the ideas and some of the learning from poorer countries to our countries to help us deal with some of the really difficult problems that we've got, and in return, of course, provided more of our health workers to work in those countries. So I think there's some real momentum around that idea and a real possibility of making that happen, which is what I'm really talking about in turning the world upside down. And that's why I continuously now talk about co-development as opposed to international development as what we need to be thinking about. Co-development, mutuality, and that we're really in a transition between a whole series of paradigms at the moment. I thought Jim's presentation was fantastic about the generational challenge. I think we're also going through a series of paradigm shifts, if you like, as to what healthcare is about. This big shift from the fact that we have in the more developed countries in Europe and America, we have these health systems that are geared around hospitals, as he said. Will an 800-bed hospital look like an odd aberration in 30 years' time? But also geared around doctors and professionals as opposed to being geared around people in the widest sense, including professionals as well as patients. So we're in a whole series of transitions between paradigms. Let's look at that a little bit further. That actually in the 21st century, we are actually subject to what I think of as 4 major disruptions. Life has changed, it's become more complex. Diseases and conditions that we now suffer from are simply different from what they were in the middle of the last century, which is when most of our systems were developed, and certainly when the NHS was developed. Patients and the public are different, they have different expectations, and we also know that for a lot of the diseases and the conditions and the problems that people have, that actually patients and the public are part of the solution as well as part of the problem, if you like. Science and technology moving on a pace in terms of the information technology, which Jim was talking about, but actually also in terms of the medical science and in all kinds of other aspects. And then we've also got this aspect of health becoming global, so that if you were running a health system, as I was in the UK, you'd need to be thinking about what was happening outside your borders as well as what was happening inside. So we've got these massive changes that are happening to us in terms of just the whole sort of concept of health, if you like. And where do you look for new ideas when such things are happening? Well, there are a number of sources. I mean, there are clearly pioneers, and clearly we see people who are pushing the frontier, who are developing new models of care, who are actually reconceptualizing the problem and starting with the patient and the people rather than starting with the doctors and systems. We can learn from other industries, and of course IHI has been great at doing that. Poorer countries I'll come back to. We can also learn from young people, because I thought Pedro's last slide about how communication had speeded up. You know, people who are being trained as doctors or nurses today, or as other health professionals, are living in a very different world from people of my generation. They are accustomed to the world being joined up. They're accustomed to using these tools in their ordinary life, and that will be affecting the future, and they will be about helping to shape the future. But I think we can also learn quite a lot from disability and rights groups, about people who are asserting that I'm not a medical problem, I'm a person. I actually need a set of services that are out there. You may label some of them health, you may label some of them social care, you may label them some education. I don't give a toss. I actually know what I need in order to help me to support my life. And I think there's some really interesting developments in some of those areas. So we can pick up new ideas from elsewhere. But the area that I want to talk about particularly now is about learning from poorer countries, learning from low and middle income countries. Now, there are a few things that has to be said, of course. Firstly, not all our problems are the same. This is a set of slides that people will be very familiar with, no doubt, that actually the burden where people are dying from HIV/AIDS is marked on this map by the size of the country. And so we know where the global epidemic is centred. But we also know that something like noncommunicable disease is now spreading around the world, and the world is getting back into some sort of similar shape. And whilst this is a very big problem in the East, you can also see that Africa is not as thin as one might expect it to be. Non-communicable diseases are the fastest growing set of problems in Africa, and they're actually the biggest set of problems, I think, in Latin America, and are growing, and you can see a rather obese United Kingdom there somewhere, which is probably a good way of putting it, in terms of non-communicable diseases. So we've got some different problems, but we've also got some shared problems. The other thing that I ought to, of course, acknowledge is that I'm not attempting to produce some kind of romantic notion here about learning from poorer countries, from rich countries. One does need to base this in an absolute understanding that for whatever the issues that Jim Easton and I and others face in the United Kingdom, the scale and size of problems that people are facing in some of the poorer countries of the world are just a whole measure of magnitude different. I normally use an example in the UK of, people who haven't been to the UK will probably know about where the House of Parliament is. There's a massive hospital opposite it, St Thomas's, which has got something like 2,000 doctors in it. It has a massive burden of disease, and it's got 2,000 doctors to deal with it. If you were in Africa, an average African country, you'd have the same burden of disease going into St Thomas's, and you'd have something like about 15 doctors. The difference is extraordinary. It's more than 100-fold in terms of the amount of staff and resource that you have got to look after people. So people in poorer countries have got a much tougher, much more uphill task than we have in our rich and more developed countries. But nevertheless, we can learn. And I want to group the learning that I'm going to suggest, firstly in terms of some specifics, and then into some much more general points. So the specifics, this is just a list. I could have produced a whole series of lists. Clearly, something like HIV/AIDS, a lot of the way in which we now manage HIV/AIDS around the world has actually been developed at the centre of where HIV/AIDS is a problem. The actual management arrangements and so on have been developed there and are now spread around the world. There are specific conditions, and I take just one example, which is clubfoot, the treatment of clubfoot, which has been redeveloped as a set of processes in Malawi, in fact, in particular, and has moved on from being about a major operation to being about effectively a manipulation. That was rediscovered in the Malawi context, where there's a lot of people with problems with clubfoot, and has been re-imported, if you like, back into the Western world, and has now become the operative or the procedure of choice for dealing with children born with club feet. Policy initiatives, we've seen there's a set of programs called conditional cash transfers, which were developed in Mexico, and effectively what they are about providing incentives to people to receive health care. They're about providing making a link between the social security benefit that a family receives and its getting its children immunised. They're providing some cash incentives, if you like, to make sure that people do the health improving things that they can do. That now has spread around the world, and it was interesting to see that only 3 years ago this was introduced into New York, and Mayor Bloomberg introduced it as Opportunity New York, and he said explicitly it was modelled on what they were doing in Mexico. There was an absolute explicit transfer of a policy programme from a middle-income country to the richest country in the world. There's then product development. Fantastic organisation called Aravind in India, who now provide low-cost eye care for, in a whole lot of innovative ways, more than just I'm going to talk about, to a large part of India now. And again, their techniques have spread around the world, but included in that was the development of a very cheap lens for cataract surgery, which again is now used around the world. In India, they reckoned they couldn't afford this expensive lens which had been developed for our rich country environment, and so they developed their own. Telemedicine, in countries which don't have wires, they are starting to do innovative things that we are only going to be able to think about in a few years' time. And what's interesting about all of this isn't, again, just a few isolated examples. It's been identified now by some of the big companies. So GE Healthcare, very explicitly, and there's an interesting Harvard Business Review article about this by the chief executive, set up a part of their organization to go and work in India and to develop products for the Indian market, which they would then re-import to richer countries. So they actually ended up producing ultrasound machines that were much smaller, that were much less complex, that were much cheaper, and which were then competing with their expensive products from their own countries. Now, McKinsey's, the management consultancy firm, at Davos, in fact, last year, produced this slide, for which I have permission to produce. And you don't need to look at the detail of it, you just need to look at where the green patches are around the world. This is where they think the 20 or 30 most exciting innovations in healthcare delivery are happening at the moment. They're all over the world. In fact, there's nothing in Europe apart from in Spain. There's nothing in China. There's a lot in India. I guess you would expect that. There's quite an amount in Africa, and then there's some in both North and South America. And so the detail of this doesn't actually really matter. And some cynic said to me, well, yes, those 30, they may be the most exciting, but they're all McKinsey's clients as well. But even if you aim off for that, I hope the general point that you will gather from this is, and know from this anyway, or know anyway, is that innovation is happening everywhere. And why would health be different from some other industries? Why wouldn't we expect a lot of the interesting innovation to be taking place in India, as it is in so many other areas? So one of the messages for us, and one of the messages that I think for the UK, but also in the work that I do for IHI, is we need to get to know India rather better. We need to understand what's going on there, because if that's where a lot of the new ideas are going to be coming from, then perhaps we'd better be listening and we'd better be learning about that. But those specifics are one thing. Let me actually move on to something else, which is that I think there's also something else that is changing, which is how people are thinking about health systems seems to me to be changing. And that you don't actually see our sort of, if I have an NHS model in mind, that we're all registered with a GP, they refer us on to a hospital, you've got tertiary hospitals, you've got doctors in all these places, you've got a structure that is over here and separate from things in the rest of society. But actually, if you look at some other countries, you'll see what I describe as an emerging tradition. You'll see much more integration of issues to do with the community, family and women. They're playing a much bigger part in healthcare. Actually, of course, in our societies, women play the biggest part in healthcare. In any case, we need only acknowledge our debt to our mothers with that regard. But people are much more integrated. And the second point that is really interesting, in somewhere like Bangladesh, where there is an organisation called BRAC that some people may know about, is that it does an awful lot of the healthcare provision in the country. But its main job isn't healthcare. Its main job is actually supporting poor people. And it links what it does on health very explicitly with what it does on education. And it links that very explicitly with helping people either get jobs or with microfinance loans, helping them to set up their own businesses. It gets rid of those barriers that we put in the way because we have started to treat in health as if it is this special industry with its own high priests and all its own rules and all the rest of it. Whereas when we actually think about it, if we think about the main numbers of patients we will be getting through hospital doors in the UK today, as Jim said earlier, there'll be people with long-term conditions who've now got an acute episode. There will be people who have a whole range of different needs for different sorts of services, and we will only be dealing with a part of them with our health hats on. So maybe there's a lot we can learn about the principles from this. There's much more about social enterprises, about organisations that are running on business lines but to social ends. There's that clear linkage between public health and clinical medicine, which we have lost in some places and never had in some others, in some of the richer countries. And there's also a very important point which I think is underestimated as one of the issues we need to tackle, and that we need to tackle with quality improvement techniques in the future, is that increasingly, or in a lot of places, people train much more for the job and not just for the profession. And what I mean by that is that across Africa you will come across people who are described generally as mid-level workers. They will be people who are trained to give anaesthetics up to a certain level. They will be the Técnicos de Cirurgia in Mozambique, where outside the capital, 97%, I think it is, of cesareans are actually done by people who are normally nurses who've had additional training. And what's interesting in 20-year studies now on this is that they do those surgeries with as few complications or as well as physicians. Secondly, they cost half the amount. And thirdly, they don't leave the country. They tend to stay in the countries, whereas the doctors will migrate down to South Africa or indeed quite possibly to Brazil. Now that, when you see that, doesn't half make you think about your own country. I think it takes you back to sort of Jim's challenge. You know, what are we prepared to face up to? What are we prepared to think about if we're actually going to get quality and cost into some appropriate sort of balance? Because what's happening there is not them saying, actually, we can't do it because we haven't got enough doctors and they're not spread around the country. We've developed a system which actually is working as effectively as the sort of system we've got in the UK. So it really is something that we need to think about. And that is increasingly happening across Africa. People are increasingly developing human resources strategies that have a bigger role, not only for these mid-level workers, but also for community workers. They still have a pyramid, if you like, with you still need the people right at the top, the mega specialists and the specialists and the doctors and the nurses and the scientists and the pharmacists, but actually a much bigger group of mid-level workers and a much bigger group of community workers. We have a staffing structure that's rather like that, with a great flat top. It's a sort of flat top pyramid, whereas in places like Ethiopia, you'll see one that has got much more of a pointed top, if you like. That, as I say, I think is deeply challenging. But if you think that in the UK, and this is true of most other systems, 65% of your costs are in staffing, then there needs to be some challenge to the fact that we have still got roles which aren't completely reflecting what's possible, what we know works. And we're now getting enough evidence, it seems to me, in the learned journals about the circumstances under which mid-level workers and community workers work effectively. And those are about proper training in the first place. They're about continuous training. They're about supervision. They're about being part of a system and being able to refer on to other people. They're all the obvious things that you'd expect. But the evidence is now mounting up. And it seems to me that's a challenge that we need to face up to in some of our richer countries. So let me move on from there. So everything that I've been arguing within this is suggesting that actually what we should be thinking about, if we're talking in terms of development issues, is that we've had a sort of top-down development of international development, where Western experts are coming and supporting people in low and middle income countries. And we've had what I think is a whole new industry of the invention of international development. And which sadly in my country I notice that we have our international development people over here and we have our health people over here. We don't integrate the two quite as much as I think we should, because I think there's an enormous amount, as it says on the last point here, that actually our health system in the UK can learn from the health system in Ethiopia and vice versa. And that part of what we should be doing is trying to find ways to put those two groups together, unlikely as it may seem, for mutual benefit. Let me just pick up a final couple of points about co-development. Firstly, there are some real benefits of having this sort of approach when you're working with poorer countries. Firstly, the developments that you are having there are much more likely to be country-led and owned rather than something that has been imposed from outside by these rich foreigners coming in with their ideas about what you should do. It's likely to be much more culturally sensitive and respectful, much more able to draw on all traditions, because there are other traditions of healthcare around the world, and part of the question is how do you use the evidence from both those traditions, both our Western tradition and other traditions, in the most effective way. It will avoid some of the faults and weaknesses of richer countries. I get asked by African ministers quite a lot about how they should be developing their health service, and one of the things I tend to say is, first of all, avoid some of our mistakes. There may be stuff you can learn from us, but actually we've also got some major problems which we can now see in retrospect we created for ourselves. And it also starts to recognise the shifting balance of power and the fact that people in other countries, other than America and Europe, are actually starting to develop their own ideas and their own thinking, which may be really quite different from what's happening in the sort of traditional health centres in America and Europe. And indeed, there are benefits for, I seem to have lost a slide somewhere in here, there are also some benefits for richer countries. So there's a slide that's missing here. But if I go from memory on that, a lot of that is about us learning about some of the minorities within our own countries. We have various areas of the UK, such as the East End of London, which has actually got a very large Bengali population who've come from, in fact, one province in Bangladesh. By thinking in terms of sort of co-development and making links between that area in Bangladesh and the East End of London, we can have our clinicians and our health workers understand much more about Bengali culture, which is then important in terms of re-importing and designing the services that are needed in East End of London. We've got partnerships now in the UK between northwest of England and the northwest province in Pakistan, where again there's quite a lot of people who are from that area who are now living in the northwest of England. And again, this is about understanding culture, understanding how we are able to provide good healthcare in the UK for our citizens. And by our citizens, I mean all of our citizens, not just the majority population. But there's another thing, of course, which this sort of co-development and this working together does. It actually allows people to sort of challenge their own ideas. And I have lost track of the number of doctors and nurses who I've met, who've gone and spent even 2 weeks working in Africa or India, who've then come back and said they've been refreshed, they've remembered why they wanted to be a doctor or a nurse in the first place. But they've also come back with some new ideas that they can import into their own country. And it can challenge a lot of our long-held beliefs and begin to unfreeze a situation where we have inherited a health system and a health service that has got some basic assumptions in it about how you do things. And sometimes you just need to see somebody else doing something different to actually understand that you can change what is happening locally. So that's the sort of background to our discussion, is that there really is a lot that we can learn if we seek to do so, and if we take off our rich country spectacles, spend some time working with colleagues in other countries and thinking about their problems and thinking about their solutions, we can genuinely start to begin to turn the world upside down, to do some learning from people who, without our resources and without our baggage, but nevertheless taking on similar problems, are coming up with new solutions. Now, what we wanted to do now, and I don't know if I can get some lights raised here, if there's anybody listening to me, or whether we can turn to the audience and actually just ask, thank you, I think that's lightening a bit, is it? Whether we can just turn to the audience and whether you could just take something like 3 minutes now just to talk to a neighbour or 2 or 3 neighbours and talk about 2 things, and then we'd like to get a bit of feedback. Imagine you're sitting around tables, and this is a task that you've been set in your table. Just take 2 or 3 minutes just to talk about what you've learnt from an unlikely source, from somewhere you wouldn't have expected to learn from. And it may be from a poorer country, it may be from somebody completely different, somebody outside healthcare or something like that. And then secondly, what you think you might be able to learn. You know? Whether there are things that actually you might now want to go out of your way to actually learn from some other unlikely source, whether you'd like to discover what they do in Bangladesh or something like that. And then we have got some microphones, I can see. What we'd like to do is to just capture some of those thoughts and ideas and have a brief discussion about that before we then turn on to talking about some of the mechanisms that we see for large-scale spread of ideas and for making some of these links across the world. Thank you very much. Was that all right? Is that all right?
Yeah.
Yeah.
That sort of set the scene.
Yeah. It's a completely impossible room because you can't see anything from up there, you know. So, what shall I do? Shall I take about Pedro? Shall I take about what, 5 minutes or so? Because I've actually gone on slightly longer. Yeah. So we'll see who got a few comments and take sort of 5 or 6 comments or something like that. And I'll hand it back to you in about 10 minutes' time.
Good.
Is that okay? That'll take us.
Hand it directly to me.
Or hand it straight on to Pierre. Yeah. Good. All right.
Just going to make sure that I can.
Was that all right? Was that the sort of? Oh, good. Thank you. Very difficult in here to get any sort of sense of whether there's almost anyone out there.
I emailed the tool right after. Tom was next. He said, "Thanks so much because it was so weird to be talking. I have no idea what the audience is. I'm just like looking at this thing and so thanks for letting me know people paid attention."
Yeah, no,
the
quite.
lights up there sounds like you went in much better space than our tool was.
Yeah, I could see this lady at the front smiling, so that was a good thing.
Can I just check? We've got 2 people microphones. Is there anything else?
No, I think that's fine actually. No, very happy. I mean, because we'll only take up.
Get one more.
Oh,
Radio. Yeah, last one. I have it.
yeah, great.
So
Okay, you lined up. Good, very good. I will then try and get some reactions. I'm going to ask for some reactions in about a minute, so. Okay, can we come back together again for a moment? And we do have 2 microphones here and here. So can I get a comment from somebody about something, there's somebody immediately here, about something you've learned or from somebody else or some unlikely source or something? And if anyone over here is going to say something who'd like to wave their hand, get the microphone. Oh, they're over there. We'll start over here anyway.
Hi, my name's Anupam Sibal. I'm the Group Medical Director of the Apollo Hospitals Group based in India. Excellent presentation, my compliments. We discovered, we run a large group. We have 52 hospitals and we have 4,000 consultants. And something we learned from technology was that, quite often, and I'm a pediatrician as well, doctors don't like to talk to each other, especially if you're in the same department and you have a complex problem. You're kind of hesitant. Right. We've always had this issue, and so we said, hey, listen, why don't we connect them? And just like you have the Facebook, so we connected 4,000 of our doctors on what we call the Apollo Clinical Excellence Forum. So you have a complex problem, you just go online, everybody's connected. You have a dermatologist who has a problem, suddenly you have 40 dermatologists in the group ready to answer that question, and it's kind of taken better because, sometimes that hesitation goes when you're actually doing this and doing it to a larger audience than the guy in the same department. So we've used that very, very extensively, and it's worked very well for us. And we've actually taken this to the next step. India has 600,000 doctors, of which 200,000 routinely get logged on to the internet. So we've created the Health Highway, and we are offering a host of solutions, just like you would say in other industries, saying, you have a complex problem, we'll help you sort it out. Doing CMEs through that and sort of basically connecting doctors. The other thing that we learned again was using telemedicine more effectively, and you alluded to that. We found that about 45% of our patients come from another city. And sometimes they come from about 2,000 kilometers away. They spend 2.5 days in a train. They've been operated earlier, and they come in, and they spend 7 minutes with the doctor who tells them, this is what I need to change in the prescription. And we found that by setting up telemedicine, we have about 100 of these centers, and the idea really for us is to set up 1,000 in the next 1,000 days, is that you actually save a huge amount of time, a huge amount of resources, and you get the same satisfaction because you get those 10 minutes anyway that you were going to get physically with doctor, and with technology being the way it is. We found that it is a huge, huge benefit, and this is something that we're really pursuing now very, very vigorously.
Well, that sounds like, busy outpatient departments in the UK. I can imagine quite a lot of relevance to that. Can we take any other comments about people who've learnt something? We need a microphone over here. Has anyone got a microphone at the moment? Anyway, well, Thanks, Lachlan. Yeah.
Just another dimension of uniting people around the world. And I love the idea of co-development and people learning from each other. For Albert Schweitzer here in the last century, the fuel for him largely was music. And there have been a number of organizations, just talking to Pedro about El Sistema in Venezuela, there's now El Sistema USA. Yo-Yo Ma says music is really all about healing. And so I bet that we could connect a lot of our work together with musicians in local communities. Young people have connected musicians globally, simultaneously doing kinds of things like that. So I'd love to talk with people about ideas about how to do that as we go ahead, to bring fuel, excitement, energy that really crosses all linguistic boundaries with a facility that doesn't happen through sort of cognitive kinds of things.
Yeah. And it connects unlikely people who wouldn't otherwise connect, is part of what you're saying. Can I take any other comments from over here? Or there's one in the middle here. Thank you. And somewhere here as well. If you want to bring...
Hi, Cathy Green. Something I've learned recently when I work in maternal health, and we have had scenarios where the midwife has been literally on her own. There hasn't been any additional pair of hands to assist her in the stage of labour where the baby's been born and she has to administer oxytocin to deliver the placenta. And literally there's nobody there with a pair of hands other than the attendant, the woman's relative who's come in to assist. And so we've been utilising that pair of hands, recognising that actually that woman loves the patient and she cares for that baby, otherwise she wouldn't be in the delivery room with her. And just thinking the extent to which we could apply that more generally.
Yeah. There's an interesting development in the UK at the moment which goes beyond health with the squeeze on public services, which is to try and get into an entrepreneurial frame of mind, which is to look for the unused assets. And sometimes the unused assets are people just like that, or they may be, you know, people who have some knowledge that you didn't know was there, or they may be buildings and so on. But thinking about the unused assets rather than trying to plan top-down what an ideal service looks like is a different mindset. I think you're going to come in, yeah.
I guess it would start with a comment from a kaumātua who's an elderly, respected person in New Zealand who taught me that health is wealth. And the story goes like he came from a small village on the east coast of New Zealand where only one person was employed, the teacher. Everyone else was on welfare or benefits. And he came to a friend and colleague of his and said, "I'd really like you to invest in my business." And the bloke said, "My wife will kill me if I invest in any more of your ventures. However, tell me about the business. What's the plan?" "Oh, it's all in my head." "And where's the finances?" Slapped his shorts, and the financial plan was on by the seat of his pants, really, is the comment. Anyway, bottom line is we're invested in this venture, and the kaumātua had noticed that people bought all their honey hives to their part of the coast because there's a plant that grows there called manuka that makes really beautiful honey. So now they ship their honey to Japan for $85 a pot. The entire village is employed, the roads are sealed, and consequently health is wealth.
Yeah. Very interesting, and it's not the sort of thing, not the way we think about health in the UK, is it at all at the moment? Any other final comments before we start to look at some of the other mechanisms? Can we take one over here? Any final one over here? We've got a microphone over here. Please. Yeah.
Thanks. I just wanted to talk about just some lessons from another industry. I worked at IBM as programmer analyst before I went to medical school. I'm now like a junior doctor at the Brigham. And I actually learned a huge amount from software industry, and it's sort of one of the industries that's driving change. I think there's a lot for us to learn because they've been managing this information complexity system for a while, and they're the people who have like some of the best access to the tools. They're often building the tools for themselves for that, but we were just talking about how in the software development world they've had this problem with information and projects of tremendously increasing complexity, and they've gone from individual programmers no longer being able to develop projects to requiring, you know, structured project management, then realizing that structured project management, the goals are too far away and the users don't know what they want, so you can't get there. And they've switched over to this new methodology called agile development, which is almost exactly like quality improvement. They just use different words, like you do test-driven development. You make small products, you make a small product, you give it to the user, they use it, and then they realize, oh, that's not really what I wanted, even though it's what I said I wanted. Now I want this. And you just give them stuff and you test it quickly. It's been a tremendous environment because we've got this other industry testing out those ideas, and they're just basically PDSA cycles without calling it that. So that's been tremendously useful. And the other useful project is if you ever do any software development yourself, you realize it's much simpler than a body, but it is a complex environment, and you can stop it at any time and look at all the variables. And more than 50% of the time, when I think I know exactly what's wrong in the program, I realize I'm wrong. And it's made me much humbler in being a resident when I'm working with other systems.
Thank you very much indeed. I think I'm going to stop there. That was a very interesting way of running around the tables, as it were. I'm sorry you didn't have enough time to talk amongst yourselves around that. But thank you for that. I hope that's set the scene for Pierre, who's now going to talk about the other part of our discussion, which is large-scale spread and what we can learn from each other in that context. Thank you, Pierre.
Well, thank you very much, Nigel. And you probably noticed in your program that the third speaker was Francis Omaswaf. And I'm sorry if you're disappointed that Francis is not here. Francis is a hard space to fill. Francis, as some of you may know, is what I consider to be the father of the quality movement in Africa. A very wise man who we've had the privilege of having good interactions with. But what I would like to talk with you for the next few minutes about is really some of the lessons that we've learned. And I hope that as I go through my presentation that some of the things that I will talk about will resonate with what you're doing in your everyday lives. We happen to be working on some fairly ambitious programs in Africa. We work in South Africa, Malawi, Ghana, and we've done some work in India as well. But I think that the lessons or that the learnings certainly that we have come across, I think in the way that we think about how you can generate a quality movement in your environment are very applicable to pretty much anybody who's working in quality and not just if you're trying to change the health of a nation. So this is just a sort of conceptualization of the various levels of a system that we need to think about when we're looking at a country, from national down to regional, down to the district, and certainly including the community. And if you're thinking about your own microsystem, this kind of hierarchy is probably pretty universal, as is the fact that there need to be two essential directions in which improvement is happening, and one is coming from the top and the other one is coming from the bottom. And what I will describe really is a sequence of how we move across this system from demonstration to large scale in a very, what I like to think is a very considered way. But what I don't want you to think of is that I'm giving you the formula, because it's not. It's very organic, as you'll see. But I think that there are some important general principles. So I want to take you on two journeys. One is a project that we are engaged with in South Africa, which is more of an opportunistic spread model, and I think it's the kind of situation that you pretty much, and certainly in my experience before I started doing this work in low and middle income countries, is the kind of way that you have to move across a system unless you're very lucky to have a big grant that you can go out and design a system from scratch. So that's the first journey, is opportunistic spread. I'll talk about the key importance of building will, demonstrating value, building capacity, and certainly building partnerships along the way. In Ghana, we in fact had a different opportunity. We did get a grant. We got a design. We were able to work on a design right from the beginning, but we encountered the same importance of going through these steps of in our design and our experiences of building will, demonstrating value, certainly building capacity ahead of spread, and the importance of partnerships, which are absolutely key to sustainability. So what I want to take you through now for both of these case examples is the progression from demonstrating results and a lot of local learning up at the front end, moving to building awareness of the QI methods, certainly building capacity to support QI if you're planning to spread, and then building a lot of support amongst the local and national stakeholders, using that initial demonstration of results and local learning to spur on the building of that will. And then you can get more ambitious as the infrastructure for quality improves, if you've developed some capacity, especially if you've developed will, and you've developed more belief in your ideas, that you have something that really does work that you can show to other people, you can start gearing up for more large-scale program execution and start to disseminate your successful results. Because what you're really trying to do is not only achieve great results at scale, but you're trying to influence the way that people think about global health, and in your case it may be local health, and also to make sure that you leave behind the resources that will ensure sustainability of whatever your program is. So I'm going to start off with the project that we started in South Africa in late 2004. And at the time that we started this, South Africa was and still is the epicenter of the HIV epidemic. There was no doubt that this was, in fact, the burning platform. South Africa has more cases of HIV, 5.5 million out of its 50 million population, than any country in the world. And it was the start of an AIDS treatment program which was being rolled out by the government. And there you can see the graph on the right-hand side there demonstrates the gap between the percent of patients who are being started each month on antiretroviral treatment compared to the need. And you can see that at the time that we started on this project, there was a phenomenal need. But I think the other important thing to look at on that graph is that the rate of improvement on getting patients onto antiretroviral therapy was very slow. So you could make some predictions about where that graph would lead if there were no other interventions put in place. I think context is extremely important. At the time that we started the project in South Africa, there was a very mixed affect, I would say, coming from the government about what they wanted to do. They were caught in this political issue of a national disaster, but I think very conflicted about how to approach it. And so it was very difficult for us to do two things. One is to operate in an environment in which HIV was politically very sensitive, and secondly, we were bringing in a new methodology, quality improvement, without any track record, without any prior proof that this in fact could work in this type of environment. Obviously there has been a lot of work that had been done in wealthy countries, but that really doesn't count when you're trying to operate in this environment. So our first few years really were spent, and some of the people in the room helped in this project, to really demonstrate that it was possible, using a whole systems approach where we would take a whole district or a whole sub-district of a hospital and all of its referral clinics, apply a quality improvement systems approach, find all the people who we had calculated would be needing antiretroviral treatment in a district each year, process them through the system and get them safely onto their antiretroviral therapy, remembering that every patient who needs therapy, who gets put on therapy, is a life saved, because that patient will be dead within 2 years if that patient doesn't get put onto therapy. So what we were able to do was demonstrate, and I've just given 3 out of about 5 or 6 district examples. We had a very specific aim: get everybody, find everybody, and get everybody on treatment within a 2-year period. And this was really crucial to be able to show that we were able to get patients more safely and faster onto therapy than was being done at the time. As you saw what the baseline, in fact you can see several of the baselines there before the quality improvement intervention started, and we were just using very standard QI methodologies, using a breakthrough series model and rapidly scaling within a district. once we were able to do those initial demonstration projects, we were able to then move to other districts, developing local partnerships, absolutely crucial in the plan to be able to capacitate for much larger spread. We started being able to show our results at a provincial level, using our partners to speak for us or to speak for the program, for the progress. And we were helped along by a meeting which was held in Bellagio, where leaders of African health systems, including Francis and Masswah, assembled in Bellagio, Italy. And we were able to show these, demonstrate together with the colleagues from URC that in fact this methodology did work, and it did work in a low to middle income country setting. Our next, as a result of that, we were then asked now, instead of moving stealthily through districts, we were then asked to take on by the province to take on 3 districts with a population of 5 million people to improve the reliability of giving mothers who are pregnant and who had HIV antiretroviral drugs to stop the transmission of the virus from mother to baby. And what you can see there is we in fact went through quite a long learning process, and I gave a presentation yesterday about the difficulties of the initial part of that program and the tremendous amount of learning that went on about how you can run into trouble with the design of some of these programs. We learned from that. We underwent a project design, and you can see significant improvement in closing the gap there between mothers who are coming to the antenatal clinic for the first time and the reliability of getting every single one of those mothers tested for HIV as the first step in protecting her and her baby from HIV. And there you can see the mother-to-child transmission rates on the right-hand side falling from about 12% in the 3 districts in 2008 to less than 5%, which was the goal in 2005, helped along by some policy changes and changes in treatment regime that came in during that time. One of the most important things, though, that happened at that time is that we were able to build a team, and key members of this team from the 20,000 Plus project are here at this conference and are continuing to build a very strong local unit which will become a permanent resource for the country of South Africa. But it really was our first ability to show that we could do this at large scale, covering a population of 5 million people over a very short space of time, that in fact it was possible using only the resources that were already available, the knowledge that was available, and the people who were available to effect a major change in population outcome over that time. As the news of this project spread, and the national government became interested and asked us if we could act as a catalyst and a convener of a number of other partners, NGO partners in the country, for a redesign of the Prevention of Mother-to-Child Transmission program, which we undertook to do over a very short period of time. 6 NGOs came together to support the districts that they were already working in to improve the PMTCT program. And one of the most remarkable aspects of this program is the willingness to come together over a common aim, which is to save the lives of babies and save babies from getting infected, to use a very similar framework and understanding, a simplified set of processes, and a very simple set of common measures that everybody could rally around. And I think this was a huge lesson about really generating will amongst a number of partners to come together around a very simple set of interventions to achieve a common aim. And we accessed 160 facilities over a 9-month period, and you can see one of the major targets is identifying mothers who need not just antiretrovirals but the full triple therapy protection, who are sick themselves, and to do that rapidly during the gestation of pregnancy. And this was a multi-site intervention, and you can see the improvement before, 22%, and afterwards in the space of just 9 months we were able to move that metric over 160 facilities from an average of 22% to 55%. Our work in South Africa really has sort of settled with 4 partners who we are rapidly capacitating to do this work, working with projects that they are in fact leading and engaged with, and IHI stepping back, providing more and more just technical support and capacity building. And what we're hoping for, and I think Pedro will touch on this at the end of this presentation, is really this concept that it's possible to leave behind or to develop anywhere in the world a really highly functional, very knowledgeable unit, what we're calling quality and resource and innovation centers, that can be a resource for that country. And so we're hoping that concept will be a major key in a strategy to spread effective quality improvement around the globe. We're now moving out of HIV into other health programs, TB, maternal child health, and hospital safety in the country. And certainly at this point now, I think with this kind of credibility, it's possible to start working at a national level, interacting with national and provincial departments of health around program advising and design of national quality strategies. And that kind of work is becoming much more sought after, particularly in Africa, as knowledge about these kinds of demonstration projects spreads. I want to talk briefly in my second case study about the experience in Ghana, which was a bit different, but really I think demonstrates the same essential principles. So in Ghana, the burning platform is not HIV. In fact, the incidence of HIV in Ghana is about 10% of what it is in South Africa. The population is about half of South Africa, 23 million. The big problem there is under 5 mortality and maternal mortality. And we were asked by the Gates Foundation to join a partnership with the National Catholic Health Service to see what we could contribute to the country's program for saving the lives of children under 5. What you'll see in the lower left diagram there is some that there'd been some progress in decreasing child mortality, under 5 mortality, between the years of 2000 and 2005. The question was really, could we accelerate that to try to close the gap and continue the improvements to reach the MDG target, the Millennium Development Goal target of a 60% reduction in deaths by the year 2015. There you can see one of the biggest issues is in fact neonatal deaths. On the right-hand panel here, you're seeing the major cause of death there, 41% of the deaths in the neonatal period. So we had to rethink our strategy, in fact, direct more of our attention towards the continuum of care rather than just taking care of the under 5 infants themselves. So this is a national project. There are about 2,500 health facilities in Ghana, and the plan was to get to all of them within a 5-year period, decrease under 5, or to support the government's efforts to reduce under 5 mortality by 60%. We were fortunate in that we have a strong partner, the National Catholic Health System, who cover about 25% of the health in Ghana, but provided a ready-made network of health care facilities that we could springboard off into the Ghana health system, and making sure we're working in close alignment with the national survival program. I want to mention in particular the IHI country director, Nana Twamdansa, who has led this program, and the NCHS director who is responsible for this program, Enoch Masswah, who is in this conference, and both of them have provided extraordinary leadership to make this project a reality. So the strategy, as I say, we did have the luxury of being able to look at the country and say, well, if we were to try to design what we consider to be an ideal project, how would we do it? And I think in the spirit of learning and scale up, we we went to the north of the country. We identified 3 areas that we started off in, and these were in the poorest part of the country to set up essentially what were learning laboratories to develop a change package over an 18-month period, and then to spread to all of the health districts in the north about a 10-fold scale-up. And then to start seeding the areas of the south with similar learning laboratories, and I'll explain, focusing on hospitals with an eventual aim to move to the whole country over the 5-year period. And using very much the stages of quality improvement, expansion, initial planning, building will, demonstrating results, building awareness and support, and certainly building capacity for QI, and moving towards large-scale program execution. And I should say one of the sort of most remarkable achievements for me of this project is that the number of staff who are running this project in Ghana has increased to about 11 to 13, and the plan is not to, in fact, increase the number of those staff, with the idea that we're building capacity so fast within the country that we will not need to expand the number of people who are working. And all of those staff, except for Nana, are working with the National Catholic Health System. So in our what we call Wave 1, which was our first learning laboratory, we really focused on the 3 drivers of under 5 mortality, really trying to develop local solutions to a whole set of very clear evidence-based interventions that were already set for us by the Ghana Health Service. However, the importance of this learning phase was really trying to find local solutions, firstly to seeking care early, making sure that we provide prompt, safe, effective, client-centered care, and making sure that data was being used for decision-making. And as you can see, this is absolutely no different to what you would think of as primary drivers for any project that you might undertake anywhere in the world. And the right-hand side of this graph of the slide is deliberately not meant for reading, but it's really meant for illustration about the useful changes that in fact were tested and arrived at as we actually developed evidence that each of the changes on the right-hand side did in fact lead to an improvement. We were able to do an analysis of the run charts for each of the test facilities and arrive at a set of clear change ideas with a proven evidence base that we were able then to use to spread in the Wave 2. Here are just 2 examples. One of the crucial targets for improvement was getting more mothers for skilled delivery. You can see skilled delivery rates in the upper panel improving from about 40% to 100% in one of the test sub-districts. You can see the Ghana Health Service asked the Project Fives Alive to test a new policy for seeing neonates within 48 hours of life. You can see the phenomenal improvement in the ability of health staff to screen a 2-day-old infant, one of the most crucial interventions in saving newborn lives. And you can see, using a quality improvement approach, what that can do. The interventions that were identified there are now being spread rapidly through northern Ghana based on this evidence. We've moved now from an under 5 population of 500,000 to 1.7 million in waves 2 and 3. What I wanted to bring attention to is Wave 3. So in the north, most of the strategies that we were testing were working with the community, moving babies into the facilities, making sure they got reliable care. In Wave 3, in a project that's led by the National Catholic Health Service, it's a specific learning around how do you save a critically ill infant and child. Some absolutely extraordinary work, some of the most really dramatic improvements that I've seen in my quality improvement career, looking at mortality rates of about 2%, which are extremely high compared to the average high-income country. And what you can see in these two examples here, dramatic fall in in-hospital mortality rates for critically ill infants over a 9 to 12-month period. We now have 4 of the 11, in fact that's a misprint, it should be 9 prototype hospitals that are now showing, almost 50% of the hospitals are showing similar types of improvement. And the learning from this is absolutely extraordinary, because we now have a change package which we feel confident that we can rapidly spread through the hospital system. So this is the eventual plan. The number of quality improvement teams, you can see, is increasing exponentially. We started off with 30 teams in the phase 1 projects, which will spread to more than 1,000 teams as the more and more facilities are accessed. And again, the bottom row shows how we're hoping to do this without a similar exponential increase in quality improvement staff to make this happen. So in summary, I asked the question, what does it take for a national spread project to succeed? And again, I think that this is not really too different from asking the same question, what would it take in your hospital or your local environment for a spread project to succeed? Well, I think this idea of really focusing people on the aim as a starting point is absolutely crucial. We've seen some projects with a more diffuse aim, with an unclear specified common aim, really not succeeding. This issue of the huge importance of getting early compelling results, reaching out to partners to get partners to work with the government, so to work well together. Early engagement with the government, as I showed you this sequence of events, we started trying to access government really from a very early stage, and as you should do with your local leaders. This idea of capacity building is absolutely crucial. You will never get a transfer of ownership of the project unless you use a very leveraged approach with a lot of capacity building. And then this idea that you design right from the very beginning with scale-up in mind, because if you're designing your prototypes without scale-up in mind, you will probably over-resource them, and you will probably end up with a model that you will then really struggle to scale, and you may even need to start over again, because the attributes of a scalable project are very different from those of a pilot project, which is not designed for scale. And then, as I have mentioned already, making sure that you're building capacity ahead of your scale-up to make sure that you have the capacity to do that. I think I've mentioned a number of these already. The issue of making sure that the unit of change is one that you can actually scale, making sure that you're speaking to all levels of the health system. I think this idea about opportunistic versus predetermined spread is interesting, because I think what it means is that you can, even if you don't have the resources to change your whole hospital, you could, in fact, start in your corner, and with dramatic results and influencing people and building capacity, you could end up with a health system-wide project by going about it in this kind of a way, showing value right from the very beginning. I think I'll probably leave it at that point and invite any immediate questions, and I think Pedro may have some others. Thank you.
We're entering the last 10 minutes of the session, so if there's any burning questions, Pierre would be keen to take them. If not, we'll probably do another 5 minutes and then have the three of us sitting here and leave maybe 5 or 7 minutes for any last question. So any burning questions immediately in relation to Pierre's presentation?
Could you discuss a little more about the point about developing, if you don't develop the prototypes with scale-up in mind, you will probably over-resource them? And can you give an example?
Yeah, I think that, let me clarify what I mean there. I think that it's perfectly legitimate to do an improvement project in your corner of the world, whatever that corner might be. What I'm saying is if you have the ambition to spread it, if that's part of your long-distance view, you should be designing with spread in mind and the type of resources that you will need to spread that project in mind while you're doing the prototype. In other words, you could bring in, and as you may see on that in the previous slide that I had there, we did have 13 people.
Ja, die liep naar toe en zei: ik vind voor een nieuwe microfoon. En zei: ja, eigenlijk binnen. Dus ik ging naar binnen, maar ik zag hem niet liggen en ik hoorde hem. Dus ik ging terug naar. Ik zei: ja.
We did have 13 people working at that at the wave 2 level, and you could say that that's actually a lot more resources than we had at wave 2 and 3. But what the point I'm making there is that those resources were not the resources that were in the facility doing the improvement work. Those were running the program, capacitating, and building the knowledge. So what I mean is that there is a danger that you could put a lot more, you could design a system that depends on a lot more resources than you have if you're going to go and scale it at a later stage. You need a lean model right from the very beginning that you could envisage in your scaled model. I don't know if that answers your question. So the question is, don't you learn in your pilot stage what you need for a model and scaling up? Absolutely. You will need your own resources as designers and leaders of the project. You will need relatively more resources. What I'm saying is, if your answer is to bring in 5 more doctors or 5 more nurses or even a learning system that is very very resource heavy, you will not be able to replicate that as you go on. So you need to be sure that you're designing a very lean, scalable model as you set out on this journey. Okay, thank you.
Thank you, Pierre. So they have taken this is a very lean operation up here. They have taken the possibility of being able to open the presentation exactly where you want. So I'm sorry for having showed everything. It's actually quite good. So let me try to bring it together and primarily try to get you to ask any questions that you may have in the end. Nigel set up the stage for us in relation to the reality that we have of interdependence, of where to learn from, and he framed 2 really interesting questions that brought in some beautiful examples around music, around honey, around programming, and so on. And then Pierre talked about an example of two countries that took very different approaches in relation to the work that we've been lucky to have been involved with, where the content in relation to a gap that needed to be closed was relatively similar, but the context was widely different. We also talked about sharing experiences and the need to transfer knowledge and the need to shorten the learning curve by being able to learn from each other and from outside of healthcare. And we all work at different levels. So in this conference, there's patients who are individuals who want to self-care and who want to just have a good life. We all want to have a good life. I am convinced that that's the end point of health and health care, for all of us to have a good life, quality of life. Many of you work in microsystems at the front line, where you go in and you do the one-to-one interaction. Many of you work at mesosystems, middle managers and senior managers and so on, who do some of the planning and so on. And many of you work at macro systems, chief executives, district managers and so on, who actually try to set up the context for people to do their job in the best possible way. And many of you work at a policy level. So there's a variety of people here, and there's a huge opportunity to teach and learn but that teaching and learning needs to be a bit more sophisticated than just saying teaching and learning. It needs to be tailored, it needs to be targeted, and it needs to be at different levels. So what are we trying to envision? What are we trying to imagine? What is the picture that we're trying to come up with based on the learning from years and the learning that we are lucky to get from many of you in this room? We've come up with a concept called Quality and Innovation Centers. A Quality and Innovation Center could be called anything. This is just a concept that helps us think about the function of quality and innovation within a system. A system could be a hospital, a system could be a community, a system could be a district, a system could be a country. So there might be many quality and innovation centers within a geopolitical entity. What it does is it provides regional or local quality expertise and leadership to maximize the effectiveness of improvement initiatives and the impact on improving health and the delivery of care, enable the results we seek to cause in the world: better health, better care, and lower cost. So what's the picture here? Pierre mentioned a galvanizing name. What if everyone in this room, what if everyone in this conference, what if everyone that works in healthcare improvement could figure out what a galvanizing name could be, where we could close a gap together and where we could learn together? So a 100,000 Lives campaign type effort around the world. What are the many gaps that we need to close? How do we actually create a global network of quality and innovation centers where we link like-minded organizations and people committed to harvesting and sharing, adopting and adapting, collaborating, catalyzing scale-up, and providing a platform to address critical topics? And in doing so, we accelerate improvement worldwide by leveraging the power of that and the power of linking people who are doing very similar job, and by accelerating applied learning from partners globally. So what could it look like? It could look maybe like this, where there's a host, which could be IHI, and there's many QICs around the world which already exist, and there's many QICs that are being envisioned at the moment that may want to link up. So what could it look like? It could have in-person meetings such as this one, or such as a very similar meeting in Latin America, one in Africa, one in Asia, where people come together to learn from each other. It could have monthly web-based sessions. It could have a home, a virtual home, a technology platform for ongoing collaboration where people exchange results, people exchange experiences, people rate the things that they're seeing in order for people to be able to access only the best tools that they're rating by looking at them. We could then harvest content experts for specific topics who are doing exceptional work in different parts of the world. We could produce electronic newsletters together, and it would have the ability to offer people access to resources across the network. This is an all teach, all learn network, and it could take many forms. So a QIC in a continent could link to many QICs in many countries within that continent. A QIC in a country could link to many QICs within that country, and a QIC within a state could link to many QICs within the state, depending on the structure and the network that's being created. And there's many examples of this already ongoing that you're part of, and many examples of it that are ongoing that we're part of, like the Impacting Cost and Quality effort, where we're working with 40 organizations throughout the US to explore how, with a shared aim of saving $30 million within a year, we could learn, harvest, and then share that knowledge with the rest of the world. So Pierre and Nigel, if I could ask you to maybe come up here in case there's any questions in the remaining 3 minutes that we have. And we would like to offer our gratitude for having been with us, for having shared your stories, and for the work that you do every day. Thank you.
Okay. Pedro, thank you for a wonderful session, everyone. Pedro, it's actually just a question for you. the QIC model is wonderful, I think, and I think from what we've seen being here at the forums that, and just I think from some of the quality work that everyone's done, is that meeting together makes a big difference. It makes things very important. But the tools that we have for sharing ideas is fantastic as well. And even just email lists with like-minded people sharing ideas that are relevant to you, it's hard to beat that. I think that one of the things that is for the QICs is that there's an opportunity to have the QICs sort of function here at the forum, and that might be perhaps the best way to get them together. You sort of have a sort of test example happening with us, which is the student and residents group. We have our own little private room, we get our own sessions. The idea being that there might be a morning at the forum that was dedicated to QICs in which you don't schedule other really fascinating talks. And that would encourage people to meet together in locals and then maybe take some of these fantastic experts like Pierre or Lord Crisp and have them go and participate in sessions there where you do some of this collaborative learning, and then perhaps for the rest of the year you just share knowledge by like an email exchange that IHI hosts. It's just sort of some ideas that I've had. It's been a great experience to network with students here, and you instantly connect vertically about common interests. So just a thought.
Thank you. Thank you. And the model of the open school is one that we have learned significantly from, and in fact, it's one that we aim to work on and improve as we continue to develop the idea of the QICs and turn it into something that's real and tangible and value adding. The main thing is that it's value adding and that it truly accelerates improvement. But with your background, I would love for you to send me any ideas that you have at any point as we develop this concept.
I'd just like to make a comment. I'm hoping that the QICs isn't going to force us into something structural and that the QIC could be an individual.
Can you elaborate, Cathy?
Will centres assume that we have a structure within a country or in a geography, but we might just have an individual, a champion, a leader on their own working, and they may want to be part of this network.
For sure,
yeah.
And yeah, that was the need to start from talking about individuals, microsystems, and so on, is an inherent need and imperative that we have to think about exactly that, because we realize that that's not the reality everywhere. That there is some sort of QIC function.
Lunch.
Okay. Thank you so much, everyone.
Thank you.